Well, good evening to you and to everybody that's joining us. I hope your day was productive. Mine was. I apologize for my scrub hat hair, but I was working the day just like probably most of you, and that's just what happens. So, as part of this thriving in an economic crisis, I think this lecture from a clinical standpoint fits in quite well because we've been through this before. Um, Phasing treatment is a way to help patients in the time of economic uncertainty. So what is phasing? Well, phasing is taking a big case that needs a lot of dentistry, and phasing is, instead of doing it all at once, which can be quite expensive, uh, do it over the course of a few years. So let's say we did this case and it took us 6 years to do, which means I put in some restorations today and then some more next year and then some more the following year. Phasing is different than sequencing. Sequencing is just the order in which you do something, but phasing is taking the big cost and spreading it out over a greater length of time. And as I said, this isn't new because we first started doing this type of process in 2008, 2009. You see, at that point in time, the housing market crashed. And what happened in my practice, which is probably similar to a lot of your practices, if you were practicing them, was the phone stopped ringing and patients stopped saying yes, right? Because we went into a recession and it was just kind of a crazy time. And I started to have holes in the schedule. And initially the holes were like kind of nice because it gave me a chance to have a break, right? But then when an hour loss of production during a day turned into a half day's loss, then I'm starting to get concerned. And intuitively you would say, well, just raise, drop your fees, make your fees lower, and then more people will do the treatment. That's the wrong way to play it. So the way to play it was, instead of saying, if we have a big case to do, instead of doing it all at once, what if we got them the ideal treatment that they needed? But instead of paying all this money down to start the case, what if we paid a little money to start? And then every year we pay a little more and a little more and a little more. And that's kind of how we came into this concept of phasing. We started this back, as I said, 2008 and 2009. So what's the goal of phase treatment? You have a big case that could be very expensive, and you do the ideal treatment that makes it financially manageable for the patient, yet still predictable for you and I. I don't want to do something that's going to increase my risk that it's not going to work, right? So the real benefit of phasing is allowing more patients to feel comfortable spending the money to move forward with their care. I mean, right now we have a lot of patients who say, yeah, I know I need this dentistry, Greg. And let's say it's 50 grand, but they go, I don't know what's happening. The gas prices are high and feds keep raising interest rates and we're going into this recession. And then there's this monkeypox thing. It's like, when's it going to end? So I'd rather not start my case now, because if I do, and all of a sudden I need this money to keep, my family going, I'm at a risk, right? So phasing is great because it allows them to start their care. Because if they don't start their care and they waited until things were calmed down, I mean, gosh, who knows when that's going to be? And it might be by the time things calm down, they don't have any teeth left to save. So the benefits of phasing it allows a lot of patients to still have security financially, but start their care to, renovating their mouth. Now, when patients do choose to phase, they have to understand that the overall cost of treatment will be higher than if I did it all at once. And the reason that the cost of treatment will be higher is twofold. Because in order for us to break the case down into smaller pieces and do some dentistry this year and some final restorations next year, I'm going to have to do some interim work. interim work that I wouldn't necessarily have to do if I was doing the entire case at once, because then it would just be provisionals. So when I phase, I have to do interim composite work most of the time, which means that there's going to be a fee for that. And the fee that I would typically charge out would be a composite buildup fee, right? So they would have to pay this, not because the tooth needs a buildup, but I need the interim change. The second reason it's going to cost more is that if I don't put my last set of definitive restorations in for 5 years, that set of restorations is going to be more expensive than today's crowns or today's onlays or today's veneers, right? Because every year our fees are probably going to go up, 1 or 2%. And so then you go, well, wait a minute. Why would somebody want to pay more to get the same outcome, the same case being done? Why would they want to pay more to get that? And the answer is quite easy, because if they didn't, they wouldn't be able to start and they wouldn't get anything done at all. And the analogy that I like to use for patients is one of buying an automobile. Most Americans, when they go to buy an automobile, don't pay the cash. They don't pay for the whole thing at once. What do? You lease it, right? You put some money down and then the bank buys the car, which means you get to drive the car of your dreams today, but you don't really own it. The bank owns it. So what do? Every month you pay a little more, a little more, a little more. Eventually that car is going to be yours, but you will have paid more for that car by having the bank pay, and you just pay pieces of it, than if you were to drop the cash all at once, right? Same idea as phasing. Now, the other goal of phasing treatment is a selfish goal on our behalf, because it can help simplify the treatment for you and I. You see, if this patient needs a rehab and desires a rehab, and I'm going to do it all at once, that's a lot of dentistry to do. And that means that when I start to prep the teeth and pack cord and make my impressions, that's a lot to contend with. So instead of doing an arch at a time, if I can do segmental dentistry and I can do sextants or quadrants, it's much easier for you and I, rather than doing like a full mouth. So there's benefits financially for the patient, and then there's benefits clinically for you and I. And at the end, I get the same level of aesthetics and same predictability in my outcome occlusally, right? So there's a lot of benefits to looking at phasing care. And I'm going to use this patient as an example, and I'm going to have a few other examples along the way, but this patient needs a rehab. And I believe that you can phase any case that's in your practice, but you have to address two main elements. The first is which is you need to manage tooth condition. So the question that you would ask yourself with regards to tooth condition would be, is there disease present? Is there caries? Is there perio? Are there endodontic issues? Essentially, what you're looking for is acute problems or teeth with symptoms. Because if that's the case, you have to manage those areas first, right? So if you look at this patient, the reason that this patient needs a rehab is he's got all of this tooth structure loss. And if I look at the tooth structure loss, it's not due to attrition. This is all due to acid. It's all due to erosion. So erosion is a slow, pervasive loss of tooth structure. There's no acute problems. Even though there's all this dentin exposed, there's no sensitivity. There's no caries. So there's not a lot of challenges from an acute standpoint. Now, what if there were? What if he had, 27 teeth, 26 teeth, and all of these teeth had caries? Well, it doesn't preclude me from doing phasing. But what it means is, in order for me or the patient to get in the game, they have to spend a lot of money to start, right? Because the goal of phasing is you don't have to pay a lot to get going. You pay a smaller fee, right? It's comfortable. You pay some more the next year and then some more the following year. But if you got 28 teeth and I got to touch 28 teeth today with pretty definitive restorations, it's going to be expensive to get in the game. But if I look at my practice, I don't have a lot of those highly diseased patients. So really managing acute problems isn't typically an issue. The next one though is you have to manage tooth position. And essentially when you're talking about tooth position, the goal with tooth position is you've got to level occlusal planes. And the reason that you need to level the occlusal planes in the interim is it allows you to start controlling aesthetics and occlusion. When you start to change tooth position, right, to get occlusal planes level, you can do it in numerous ways, right? So once you get the arches leveled, I can sequence through the case in a bunch of different ways, meaning that when we get into the idea of phasing, there is no right or wrong answer to how you proceed and sequence yourself through the case. Once I get the arches level, I can kind of do whatever I want, but the goal is you got to get the arches level. So to level the arches, we can do it additively. So I can add composite, I could place provisionals. I could even start placing my first round of definitive restorations, or I could do it subtractively. I could plasty and adjust teeth or adjust existing restorations. But the overall goal is you got to get the occlusal planes level. So we can do it temporarily by reshaping or composite or prep and provisional while we place our first round of definitive restorations on certain teeth. But also you need to keep in mind that one way to help phase and one way to help level occlusal planes is using orthodontics, right? Because leveling occlusal planes orthodontically now means that I don't have to touch as many teeth. My goal when I start to phase is the less I have to do something to a tooth that's additive, the better off I'm going to be. And what I mean by that is if I can subtractively level occlusal planes by adjusting teeth, then there's no maintenance issues. I don't have to upkeep something that can chip or break or pop off. Anytime I go to place provisionals or bond composite to get occlusal planes level, there's always that risk that something happens to it and now I have to manage the chipping or the failure that occurred in the interim. So if we look at our patient that we're considering phasing, and I go back to leveling occlusal planes, what you notice is the upper occlusal plane actually is relatively level. Now, we obviously have some additive things to make it more level in the anterior, but the posterior occlusal plane is actually quite level. If you now look at the lower occlusal plane, different story. On the lower occlusal plane, the lower anteriors are actually stepped up relative to the posterior teeth. So we'll have to figure out how we can level the lower occlusal plane again to help us phase. So why is that important? When you have aberrant occlusal planes like this, you typically have no room for restorative materials. Those lower anteriors are super erupted into the significantly worn palatal of the upper anteriors. So leveling occlusal planes allows me to get room for materials, but it also allows me to control occlusion and occlusal forces. You see, if you're going to be leveling occlusal planes and you're using provisionals or you're using composite, having an occlusal plane like this makes guidance really tough, which means things have a higher risk of breaking. Leveling occlusal planes allows me to control overbite, control overjet, and by doing so, control forces. So when I think of phasing, I think of it in two parts, right? There's a planning part of phasing and there's a treatment part of phasing. In the planning part of phasing, just like you already do today, you have to identify the current problems, right? Here's my problems, here's the etiology, here's my diagnosis, right? You always have to provide a diagnosis. And then what you're going to do is you're going to determine the correct tooth and tissue position, just like you're going to treat it all at once. So you're going to follow basic facially generated treatment planning protocols using aesthetics, function, structure, biology, and you're going to figure out where to put teeth and tissue, what type of an occlusion you want, and you're going to develop your treatment plan as if you were going to do it all at once. Even though you're going to break it up and phase it, you need to know where you're going. On steps 2 and steps 3, you're going to start to develop the treatment plan. So step 3 is, again, if you were doing it all at once, how are you doing it? Are you using ortho? Are you doing surgery? You're going to open vertical dimension. What is it that you're actually going to do? Okay, so you need to know the big picture. And then when you bring phasing is, you now need to realize, okay, since I'm not doing it all at once, what are my phasing options to allow me to get to that endpoint that I desire? Right? So you still plan steps 1, 2, and 3 like you were doing it all at once. It's only when you get to step 4 that you have to back it up and go, okay, knowing where we are, knowing where we choose to be when we're done, how can we break it up and phase it and do smaller pieces? Which teeth am I going to do first? How am I going to get occlusal planes level? Does that make sense? In the treatment process of phasing, we then begin to manage any disease, if in fact there was some. We begin to do our phasing, our interim change of tooth position to level the occlusal planes. And then we have to manage the etiology. This is key, right? So the patient that we're going to be talking about is a big erosion patient. If I don't address the etiology, the risk would be he erodes out from underneath my eyes. I start my care, and then by the time I'm done, the first definitive restorations I put in have already started to fail because of erosion, right? So we have to address the etiology to prevent further and continuous breakdown. So now let's apply those steps to our patient here. So current condition etiology, this is gastric reflux. We know this by patient report that he's on an anti-reflux med. He's been diagnosed with reflux, but it's also in which teeth and which positions of the teeth that are worn. So reflux is where on the palatal of maxillary anteriors and the palatal of maxillary posteriors. Reflux also is occlusals of lower posterior teeth. Okay, so he kind of fits the classic gastric reflux. So the etiology and the diagnosis are vastly important, right? Because we don't want patients to continue to get worse as we start our care, as we start our treatment. So now we're going to begin to correct tooth position and tissue position. We're going to go back and we're going to treatment plan the case as if we were going to do it all at once. So when we treatment plan, remember, facially generated treatment planning uses the building blocks of aesthetics, function, structure, biology. And when we treatment plan, we always treatment plan from the top down. We walk through and we figure out where do we want to put teeth and tissue. And we go to what type of occlusion we want, overbite, overjet, vertical dimension. Structural treatment planning is the restoration of teeth and the replacement of missing teeth. And then the biology is the health of the system. So that's the treatment planning. We don't treat in this order though, right? We don't treat by putting crowns on the anterior teeth first, right? Treatment actually is in the reverse order. When we treat, we start with biology, and then we do structure, we do function, and we do aesthetics, right? We end up with our final aesthetic goal, and we know it's going to look good, even though it's the last thing that we do, because it's the first thing that we did when we treatment plan the patient. When we start to position teeth aesthetically, we go back to the fundamentals of FGTP, which is look at the teeth relative to the face. And so given his age, he's late 60s, he's got enough incisal edge position in repose. And typically with the reflux patient, the lower anteriors look great, right? They're the least impacted by the acid. So looking at his teeth, do I really need to change the position of the anterior teeth? And the answer is Lower anteriors, no, but also upper anteriors, no. Now understand that the palatals of the teeth are wiped out, but the incisal edge position really isn't going to change dramatically, especially really not so much on that left central. And then if you look at the laterals and the canines, they're in a reasonable position, right? They're in a reasonable position. So there's really not a lot of aesthetic change required on the upper anterior teeth. And again, if you look, his occlusal plane on the posterior is level, because again, I want an aesthetic and I want a functionally leveled occlusal plane. Well, if I leave the anteriors where they are, the posterior occlusal plane is already level. So what does that tell me has happened with the posterior teeth? The posterior teeth have a ton of occlusal wear, but they haven't erupted, have they? Or they have erupted a lot, haven't they? Because if they haven't erupted, we'd have a step from the incisal edges of the anterior teeth to the posteriors. So they've erupted quite a bit because the occlusal plane is correct and the teeth are visually short, because ideally where we would want the teeth and tissue to be would be somewhere here, right? So these teeth have worn, and as they've worn, it's almost as if they erupted at the same rate that they lost tooth structure. So the occlusal plane's already level. When we look at the lower arch, it's a different story. The lower anteriors are fine. We don't need to change those, but the lower occlusal plane is actually sitting more apical. So the upper anterior teeth wore and erupted, the lower anteriors didn't. Because in order to level the lower occlusal plane, I would want to raise the posterior occlusal plane. So this is kind of where I would want to put the lower posterior teeth. So just as if we go through the basis of facially generated treatment planning, I got to figure out where I want to put teeth and tissue. And once I figure out where to put teeth and tissue, I need to be able to design an occlusion. So now what determines the vertical dimension? The anterior teeth determine the vertical dimension. And the vertical dimension is really the palatals of the uppers against the incisal edges of the lower anteriors. Okay, so the big problem you have in these wear patients is all of these teeth are in occlusion and they're severely worn. So you go, well, how am I going to get room to restore all of this wear? Well, now imagine if you actually started to put some resin on the palatals of the upper to cover the exposed dentin and replace what the natural tooth would look like. And then you didn't touch lowers because they actually don't need to be touched. And then you closed the patient, had him bite together. By adding material to the palatals of his uppers, you would have actually opened his vertical dimension of occlusion. And when you open the vertical dimension, you start to get room to restore the wear and loss of tooth structure on the posterior teeth. Okay, so we know where to put it. We know that we're going to basically do this restoratively. And because he doesn't significantly show the gingival discrepancies on the posterior teeth, we're going to leave the posterior tissue where it is. So actually, this case can be treated all restoratively by using vertical dimension changes to get room and level the aesthetics of the occlusal planes. Now, from a phasing standpoint, in order for me to even start, I'm going to have to start bonding composite. All right, so if this is what I need to do, I can actually use composite, which I'm depicting here in blue, to be able to start to make the changes to get my occlusal planes level. And the composite can either be done directly, right, directly in the mouth on the teeth, or it could be done indirectly on a cast and then brought to the mouth finished. So if I'm going to be thinking about using composite to open up vertical dimension, and once I get everything built up, I would start to consider, okay, how many teeth can I do per year into ceramic? This composite may be in the mouth for 3 to 5 to 7 years before everything is replaced with ceramic. So the question that you would have would be, how well is composite going to work if you use it to open up the vertical dimension in situations such as this? Well, if you go to the literature, this is a nice paper looking at the survival rate and clinical performance of composite on situations as if we wanted to do it, using it to treat tooth wear in open vertical dimension. Okay, so what they're going to look at on this paper is over 200 restorations and 31 patients opening vertical dimension by using composite. And then they're going to follow the patient and see how the composite did. They're going to follow them for 5 years. So major failure, which is what they classified as, it was such a bad problem that they had to replace the restoration, was uncommon within the first 5 years. Minor failure, they classified as wear of the material, chipping at the margins, discoloration at the margins. That actually occurred. So overall, the median survival rate was almost 5 years, 4 years and 9 months when all types of failure were considered. If I think of my patients and I think about phasing them, I would say most phasing occurs 3 to 7 years. So if it's about 5 years that most of them fit, composite will work quite well. And the fact that you start to get a little bit of chipping and wearing and marginal discoloration is a good thing. It's a good thing because once you build things up in composite and you improve the aesthetics and you level occlusal planes and you help their occlusion, they look and function way better than they used to. So we have experienced patients that once we do this, we never see them. They never go to the ceramic phase. So the fact that things start to kind of break down a little bit and get a little ugly is actually a good thing, because otherwise they might just sit in the composites for way too long. In fact, what I will tell my patients is this: when we start to figure out the phasing, remember the phasing part of it is how many teeth can you do a year? Here's the fees. You know the fees are going to go up. And they would say, okay, I can do 2 a year. I can do 2 restorations a year because maybe I can actually kick insurance in to help. So as long as they do their 2 every year, if they have little problems and things chip or break or come off, part of my service is I will fix that for them, no charge, just an office visit, right? Cover my PPE, these types of things, but I won't charge them for the dentistry. If, however, they break their contract with me, they break their promise, they don't do 2 that year, when they have a problem, I tell them I'll still help you, but now I must charge you, right? Because you've broken your contract. So now I have to charge you to fix it. And honestly, when I charge them to fix it, I make it sting, right? I make it hurt financially. It's not just a little composite repair. I will charge them again. And the reason I would do that is if they have to continually now pay money and they're remaining static, there's no benefit to them. I want them to see that they're not going anywhere and you're still wasting more money now. So if you continue on and you continue and hold up your end of the bargain, I will cover my end of the bargain. I'll help repair things. But if you don't, I got to charge you. I don't tell them that when I do, I'm going to charge you a lot, but I charge them a lot. So typically what you find is it doesn't happen again. They will catch back up in the game and they'll start paying and doing however many they said they would do initially. Now, composite holds up really well for 5 years. And again, in other patients, in an erosive patient, composite is perfect material. It might not have any problems at all. The attrition patients tend to have more issues. The question will be, which composite do you use, right? Some sort of a hybrid, microhybrid, a microfill, or one of many nano types of materials. I'm going to make this one easy for you. If you look at materials of composite, because I love materials, Composite is interesting because all composites in essence are the same, meaning that they have an inorganic matrix, which is your filler, and then they have an organic matrix, which is your resin matrix. And they have an organosilane that basically bonds those two components together. So really what makes composites difference is the inorganic matrix, the filler, right? It's how you and I judge materials. Like everybody likes, oh, I like my composite to be smooth and creamy. And another goes, well, I like mine to be a little more stiff. That's all fillers. What are the sizes of the particles? How many particles do you get in there? What are their shapes? So in a sense, each type of composite has benefits and risks, right? So hybrid and microhybrid composites are great because they're strong because of their particle size. Their downside is they don't polish well. And when you do get them to shine, the shine doesn't last very long. Microfills are the opposite. Microfills polish really well and they hold their polish very, very well. They're just not very good under function. Nanomaterials actually kind of take the good of both of these and remove the bad. So they polish well, they remain polished for a very long time, and they have enough strength to be used in areas of function. So I'm going to just show you one paper looking at which materials you should and shouldn't use. In this paper, they're going to also use direct composite to build up vertical dimension, and they're going to look at it 30 months. They're going to use two types of composite, a microfill and a microhybrid. Okay, so what's the overall difference? Microhybrid, strong. Microfill, not so strong, but really pretty. When they compared it overall, 30 months, remember, their success rate combined was about 90%. Okay, if you break it down into microfill versus microhybrid, the microfill is terrible. It sucks. Don't use it. Use anything but a microfill and you will actually have a pretty high degree of success. So nano, hybrid, microhybrid, use one of those. Just don't use a microfill. Now, if you're going to phase and you're going to use composite to level occlusal planes, you got to get the composite onto the teeth. So the two ways to get composite onto the teeth, well, three ways really. You could freehand it, but that's not a good option. So really it comes down to me that there's two ways. You're going to use some form of a clear matrix to help shape the composite quickly, or you're going to use some sort of a lingual or palatal putty matrix so you can actually make a shell of material. When I'm considering phasing, I'm actually going to use some sort of a full contour matrix. Something like Copyplast, which is what you see on the screen here, or a clear bite registration material like Memocell, right? So I'm going to use something made from a diagnostic wax up, which is going to rapidly shape the composite and allow me to cure through it. So I need to have it clear so I can get a light through it. So if you were going to phase, if we're going to phase our patient, I'm going to treatment plan it like I'm going to do it all at once. And then I'm going to have a diagnostic wax up performed to make everything ideal, tooth form, tooth shape, occlusion, like I was going to do it all at once. Okay, so I'd have my mounted diagnostic casts. And the one thing I would instruct my technician is, I want you to do your wax up and do it as an addition of wax only. Most technicians, when they start to wax a tooth, they want control of the entire contour of that tooth, which means they prep it back so they can add wax everywhere. If I'm going to be phasing it, I don't want that, because I'm going to shape the composite with a matrix. And that matrix needs hard tissue reference points, hard tissue stops for stability. So when it's placed, it's shaping the tooth like the wax up in the exact position. So I need to have parts of adjacent teeth or parts of that tooth that I'm not touching. So the matrix fits on the wax up exactly like it fits in the mouth. Now, I'm a big fan of going digital when digital becomes beneficial. I think the analog world is a better world to live in if you're going to phase. And the reason is this: when I have an additive wax up done in the analog world, conventional wax up, when I'm working on the patient, I have that cast sitting on my bench top, sitting on the clinic. And the reason is I can look at this and I can go, okay, this is how much wax is added. So it cues me in as to how much composite to place, right? If you have a digital wax up and you print a model off the digital wax up, the whole thing is resin. You have no idea how much of that resin tooth you see is composite and how much is natural tooth, right? So the analog world here is going to win. So what you're going to do is, once you get your analog wax up, you give it to your assistant and they duplicate it and pour it up into stone. And I use a lot of copyplast matrix, 1.5 millimeter copyplast. Again, you could just squirt clear bite registration material around the wax up and not have to duplicate it, but I like the copyplast. Once I get the copyplast and I've had it trimmed, when I get to the mouth, I do one tooth at a time. Even though eventually I want all of the uppers to be treated, I don't start that way. I do one tooth at a time, and then I treat the tooth, right? I isolate it, I air braid it, etch it, bond it. I build it up with composite. I slide my matrix over the top. I cure through the matrix and it shapes the tooth. And then I must finish and polish that first tooth I do before I move on. And the reason I treat one tooth at a time is, if I don't, you'll be quick, but you will have just bonded all the teeth together. And then it's going to be ridiculously slow trying to separate the teeth. When I do one tooth at a time and I get the first tooth polished, when I get material that goes over to the tooth I just finished, as long as it's got a polish on it, the composite will never bond. It'll never stick, which means I can take an instrument between the teeth, turn it, you'll hear a little, right? The teeth move in their PDL. I get a little separation, and then I can get my discs and my, number 12 blade in there, and I can start to finish it back. So let me just illustrate how that would work on a patient that I'm going to build these lower composites up pre-orthodontically to help the orthodontist. Okay, so I would end up making impressions and doing an additive only wax up. Now, this patient is going to go into ortho, so I'm not making the teeth look pretty. I'm making the teeth the correct size. And then orthodontically, the orthodontist is going to move them into the correct positions. So I would do my wax up, I would duplicate it in stone, and I would actually pour it up in stone, make a copyplast matrix, 1.5 millimeter copyplast. And then I'm going to isolate, and again, a nice way to isolate, I think, as opposed to using a clear Mylar strip, is if you have contacts on the teeth, use a a Toffelmeyer matrix, because it's stiff. So when I come in and air braid it, I don't blow my matrix away. Okay, so I can keep that matrix in, I can air braid it, then I can etch it, I can put my adhesive on, and then what I would do is I would look over here and say, okay, how much composite do I need to add? And then I would add it onto the edge of that tooth. I would slide the copyplast matrix over it, and I would cure through the copyplast matrix and cure the material. Okay. Now, there's only one cardinal rule you cannot break when you're shaping your material with a matrix. You cannot have too little material. You always have to have more than you want, more than you need. And the reason for that is, if you don't put enough composite in, and then you slide your matrix over the top to shape it, you're going to get crazy voids, crazy bubbles that are going to be beneath the outer surface. right? You're going to see them through this little thin shell of composite. And to go after them and fill them in is a problem, right? So knowing the rule, the first one you do, you go, okay, I added way too much material then, and it takes maybe a little bit longer to finish it back. But again, I can flick this little ledge off and I don't have a lot of flash, but I would finish and polish that first restoration. Polish it to the point that it's shiny. And then I'm going to move on. Now, what I used to teach and what I used to do is I would teach every other tooth, right? I would go canine and I would do this and then I would do that. Because the first round that you do is pretty quick because there's nothing treated on either side. And then you would come back and you would do the ones in between. And what I found was, even though I'm pretty quick on the first step, when I do the ones that have an adjacent tooth on either side already restored, I get slow. And so now what I would say is I would do it in sequential order, meaning I would do like central lateral canine, central lateral canine. The benefit of that is once I do the first one and I do the one next to it, I have one free side that nothing's been done and one side that actually has a contact. And what I find is I'm actually quicker when I do that. Now, here's the other benefit. When you start to do it, notice I just built up this other central. Once you put the first one on and you go, wow, that was way too much material. When you do the next one, you grade yourself and you get it a little bit closer. So by the time you start to get to the last few, there's not much flash that I need to clean up here, right? You can see that this is really getting to be quick because I'm better estimating how much material is just a little bit more than I'm going to need. So in a very short appointment, I can build all of these teeth up with composite. And that's, again, if you were going to phase, it's the same idea. You're going to rapidly shape the material with a matrix. Now, what if you have patients who have existing dentistry that you want to do additive to? Well, as long as it's not a gold crown, you can bond to ceramic, right? We bond to ceramic all the time, but you need to change that ceramic. You need to roughen it up. You maybe need to aerobrate it to roughen it up. If it has glass in it, then maybe you need to do some hydrofluoric acid, okay? So I would aerobrate or I would prep the teeth, and then you would do styling if it's a glass ceramic. If not, you would just go ahead and put your zirconia primer on if it was zirconia, and then you would build it up on top with your composite. Now, here's the one caveat. If I have a certain amount of bulk of material, right? The whole thing has bulk to it, it'll work really well. If you're only having some that kind of fits onto the occlusal and then it disappears as it gets to the cusp tips, you're going to have a problem, right? Because materials need a certain thickness for their structural durability. And what I found is if my composite has thickness in the central groove and I'm shallowing out the central groove, as it thins out near the cusp tips, right, and it gets really thin, those areas chip and break away. So you get this island of composite in the fossa, and you get this moat, this gap around it. So looking at the wax up, if it has a disappearing margin to it, I actually would come in and I'd prep the cusp tips so I get more composite material, because that thickness is what's going to be needed to be able to give it some longevity. Right? And then we would manage any active disease on this patient once we're ready to go. There's no active disease to manage. And so we're going to now build the teeth up with direct resin. And I would suggest starting in the anteriors, and again, going tooth by tooth by tooth and finishing and polishing before you go to the next one. Okay. So here's the additive wax up. And it's pretty ugly, isn't it? Right? Because you're only adding wax where you're missing tooth structure. Now, what I'll tell technicians is if you got a tooth that's like way outside the arch for that you're going to want to bring back, you can go ahead and adjust that tooth and bring it back. But you need to tell me what you did. And you need to remain with an untouched set of casts so I can see how much you ended up bringing that tooth back. Because what I'm going to have to do is I'm going to have to adjust that tooth and try my matrix on, so the matrix I know actually slides over the top of it. So you would think that technicians don't charge us as much if they only wax up like the parts of the teeth, but they still do. They still charge us full fee. Okay, so then we're going to isolate individual teeth. If need be, we can start to put like grooves, retentive grooves. If there's a canal, we can go into the canal. I would section the matrix, and I'd have a piece that fits canine to canine, and then I have a segment that goes over the posteriors as well. So individually then, we would build up tooth by tooth by tooth. And now, once the patient bites together, you have opened the vertical dimension, right? Because we waxed the palatal and added material to cover that exposed dentin onto the palatals of the teeth. But now, opening the vertical dimension allows us to have room to restore the posteriors on the upper and the lower. So the anterior teeth, aesthetics, the overbite overjet determine the vertical dimension for the patient. So now the posterior teeth on the upper arch, still going tooth by tooth, finishing and polishing along the way, have been restored to get the occlusal plane level and get the tooth form back. And then we would do the lower posteriors the same way. Okay, now I'm charging these interim composites out as a composite buildup, which means you can't leave any old cruddy material. So when we come back and prep these teeth for definitive restorations, you treat what you did as a buildup, right? Because if you cover up something, you never know what's happening underneath it, which would mean that you could be trapping caries and creating a problem down the road. So everything has to be removed, and I treat it like a true composite buildup. So here's a patient whose entire dentition then in one appointment is all built up out of resin. And now you would have preset how many teeth can you do? And the patient might say, I can do 4 teeth a year. I can do 2 teeth a year. And you start to sequence through and finish things into more definitive materials. That's the idea of phasing. It allows more patients to say yes to the dentistry that they need to help preserve their teeth. Because if this guy said, listen, I got to wait till the world calms down, man, you're not going to have any teeth left by the time the world calms down. That acid is going to just erode all of them. Okay. Now, you would also then determine, again, as I said, how many teeth you would do at once, quadrants, an arch, 2 teeth, whatever it might be, but it's between you and your patient. So now let me just walk through another case with you in our remaining minutes together. In this case, I'm going to actually use composite for definitive materials, but it would be the exact same idea if I were to phase it. Okay, so best cases to phase are erosion cases. This one fits into that. Okay, so you can see the anterior teeth are broken down, and if you look at her, she wants to improve the aesthetics of her anterior teeth. But if you have her bite together, you go, how do you lengthen the short anterior teeth if she's biting on the edges, right? So I'm going to use composite to treat her as definitive materials. And I'm going to treatment plan it based on where I want the teeth to be first. And I think the composite's going to work quite well with her because I believe this is all erosive. This is all acidic. In fact, there's only one facet that I can see. And the facet is on this lower anterior and on this upper lateral, right? It's a really flat line facet. Okay, so I'm going to end up plastering the lower lateral to be able to get room to lengthen the upper lateral. So I shouldn't have a problem with wear patterns. So we use our templates to determine where you want to put the teeth. I want to lengthen the anterior centrals and the laterals a little bit, because now look at the anteriors relative to the posterior occlusal plane. It's pretty level now, isn't it? I need to lengthen the cuspids, but not very much. Okay, so I need to do more length addition to laterals and centrals and minimal to the canines. So I mount the case and I start waxing, and I do my aesthetic changes onto the teeth. And then I go, all right, close the articulator and look at how much room I created. Well, knowing that I don't need to add much length to the canines, I go, that's too much room. I can't close that down without making the canines too long. So how do we control vertical? Upper palatals, lower incisal edges. So I can remove some off the palatal of the upper, and I can adjust the incisal edges of the lower anteriors until I get the amount of room that I could close the posterior occlusion. So once I get it here, I go, okay, I got to add a little bit of length onto the canines. This looks much closer. I can get those teeth to touch. I finish the wax up. So now what you see is everything in beige wax is going to be made into composite. I got room by decreasing the thickness on the palatals and hitting the incisal edges on the lowers. Because this is going to be definitive materials on the anteriors, I'm going to want to layer it. So when I layer, I use a palatal putty. If this entire case was going to be phased, I would do the whole thing using some sort of a clear matrix. All right, so I'm going to layer the anteriors. I'll do the centrals together, then I'll do laterals together. And then I'm going to do individual using the copyplast matrix to shape the posterior teeth. So this is what she looks like when she leaves the practice. I've restored all of the wear. I've lengthened the upper anteriors, and I've opened the vertical dimension. And again, so she's got restorations here. And if you remember the wax went into a disappearing margin near the incisal edge, cusp tip on the facial and palatal. So I would prep some off of it, and then I would add it in bulk. So now I have a thickness of composite onto that surface. When you're bonding composite and you have to, remember I said you have to remove old restorative, you would treat the DO as a separate DO, right? Use your sectional matrix, treat the DO, and then I would add my occlusal composite and shape that with the matrix. Don't try to do the DO and the occlusal all at the same time, because you're going to get a mass of material into the contact that you're never going to be able to remove. Right. So I would treat this one as well. I would do the distal part of it the same, and then I would shape the rest of it. Once the initial is cured, I'd shape it with my matrix. Right. So this is the way she leaves the practice. And again, could we have closed black triangles with composite as well? Absolutely. But she says, no, I'm fine with that. I just want to be able to show more teeth when I smile. So this could be thought of as phasing. But in this case, because I don't think she's aware risk, this is definitive materials for her. So I can keep costs down. Now, lastly, one more case. If I could do it directly on a cast, on a model, and then take it to the mouth already done, it makes my life so much better, right? I'd always like to be more efficient clinically. So you, in certain patients, can do indirect composite buildup. So do them on the lab bench or have your technician do them, and you take them to the mouth and just bond them in place. Still requires a wax up, and then you can either make them CAD CAM, right? Scan the tooth, scan the wax up and mill it, or you could actually use direct composite and matrices on your stone and then take it to the mouth, which is what I'm going to do for this patient here. So she's got a really rare syndrome, and she just finished ortho for 5 years with an orthodontist and a prosthodontist overseeing it. And once they pulled the brackets off, the prosthodontist goes, I have no idea what to do, right? So they say, go see this guy. So I look at it and go, well, the reason that you don't know what to do is the teeth don't look like teeth. In fact, these are actually good teeth. It's like a peg premolar and peg molars, but they have good roots. So she has a tooth size issue. So what I'm going to do is I'm going to phase it. I'm going to change the shapes of her teeth to allow us to start positioning teeth in a better position. And I'm going to take an impression and just wax what I think the tooth is missing. That's it. Not looking at occlusion, just keeping the curve of speed that you see, wax what you think is missing. I initially had planned to mill these composite buildups out, but given that they're disappearing margins onto the teeth, I just duplicated it, and I'm going to use composite because I know I can't mill to 1/10 of a millimeter, right? It'll shatter and it'll chip. So I make, with my clinical composite, I make 8 composite onlays on the cast that all I have to do when I get back to the mouth is air braid the teeth, and I go etch them, bond them, done. Quick. Could you have built the individual teeth up in the mouth? Yes, but you wouldn't be this fast. So I'd much rather be efficient in the mouth and pay the technician, or in this case, I did them on the lab bench myself. Now we can start the ortho on the lower. The anteriors, the canine and the laterals, they look different because before we built them up, I had my surgeon expose the anatomic crown, and then I built these ones up directly in the mouth, like I did the lower anteriors I showed you previously. Do the same thing with the upper. But because we're having ortho done, I'm going to look at a radiograph to figure out the inclination of the teeth. And I'm going to mark it on the cast. And then when I wax it, I'm going to wax the crowns in the correct inclination. That way, when the orthodontist sees it, they go, oh, I see this tooth is tipped mesially. I need to upright it. So when they're done, the roots are in the right spot. So now the teeth are bonded in place. The only ones that I could not do on the cast and bring it to the mouth done would be the centrals and that canine. Those ones are shaped in the mouth like I showed you earlier. So now you look at this patient and go, all of a sudden, I'm not an orthodontist, but this case looks a lot easier, doesn't it? So I can align the teeth, space appropriation, and then I can do implants. And then it doesn't even matter if she moves this material into definitive materials or she stays with a composite on the adjacent teeth. So it allows her to remain in a very stable position for a significant period of time. All right, so I think, excuse me, I think you can phase any patient in your practice. Tooth condition and leveling the occlusal planes is the key. We do have a workshop at Spear that is all about phasing. And it's actually, the challenge with it is it's one of the last workshops and you can't take it until you've taken a lot of the prerequisites, right? It used to be the end of our curriculum. At the end of the core curriculum would end with complex treatment planning, sequencing, and phasing. But as of next year, Jeff Rouse and I are developing a class called Advanced Treatment Planning, which will be the new end to the core curriculum. But we do go through treatment with phasing, different types of techniques, injection versus shaping, silicone versus copyplast. So it's a really nice kind of hands-on heavy class. All right, so I see there's a couple of questions. Heated composite. If it depends on what composite system you're using. Okay, so heating composite doesn't change anything except its flow characteristics before it's cured. I use a lot of Estelite composite, Estelite Omega. When Bob and I used to teach the composite workshop, this was the material that we would teach with. If you've used that material, it actually flows quite well, which means that I wouldn't choose to heat that material because if you did, it almost becomes a flowable. If you're using something that's stiffer, then you might choose to heat it because it'll flow better when you shape your matrix over it, right? So it all depends on what material you're using. It doesn't change anything except the characteristics of how it feels when you work with it. Is this info available at Spear Online? This is available as a study club module. This is available as a study club module, which goes into it in greater detail, and I think it uses different cases as well. So look through at the study club modules, and there, I think it's called phasing. For additive composites for the lower anterior, you mentioned using a Toffelmeyer band in the lower anteriors to isolate. Then you mentioned using a copyplast directly to shape the composite. Yes, you are correct in assuming, so the Toffelmeyer or any type of isolation matrix is only to isolate it while I prepare the tooth, right? Because if I air braided and I air braided the adjacent tooth, or I etched and put adhesive onto the adjacent tooth, now the composite, when it squirts over there, it's going to bond. I don't want it to bond. So once I'm ready to put the composite on, I would take the isolation matrix off, and then I would put the material on the tooth, and then I would actually seat the matrix over the top. I oftentimes get a question, do you put the material directly in the copyplast matrix? I don't. And the reason I don't is it's harder to gauge how much material you need. And you typically overshoot it, which means that when you go to seat it, you have so much thinking material, you can't get it seated correctly. Okay, so I put it on the tooth and I'm looking at the wax up to gauge how much is on there. And remember, go a little bit plus. I slide the matrix over the top, and then using my fingers, I make sure the matrix is seated, not by pushing on the tooth with a composite in it, because I could squish the composite since it's not cured yet. But I push maybe on the adjacent teeth, and I focus on the area of the tooth that doesn't have composite on it, right? The apical 2/3 of that tooth was all natural tooth, so I press there. Do I recommend occlusal guards? It depends. I'll tell you what, I used to recommend everybody gets a night guard, and now I'm not that guy anymore. The patients that I showed you, the two that were erosion based, they don't need a guard. They don't need a guard because they haven't shown me they need a guard. All of their tooth structure problems are due to acid. So I need to control the acid. That's primary. If it's an attrition patient, yes. If it's an attrition patient, to control the etiology, I need to be able to manage further breakdown. So then the question becomes, well, which arch do you place the night guard on? And my recommendation would be whichever arch you're going to start doing your definitive restorations on first, make it on that one. Because the benefit is you don't have, like, I'm okay adjusting occlusion on it, but I'd rather not have to hollow grind it out every time I put a new crown in. So if I do this upper left segment first, then my night guard goes on the upper arch, which means that when I make it, those teeth are going to be solid and I never have to reline it on that. Copyplast, is it stiff? It's not, yes and no. Copyplast comes in different thicknesses. For shaping composite, I use 1.5 millimeters. If I'm using copyplast to shape a provisional, I also use 1.5. It's stiff enough that it actually doesn't lose its shape or distort, but it's also as accurate fitting as if I used a thinner material. The benefit of copyplast is that nothing sticks to it, right? And again, the main goal here is copyplast is important, but what's even more important is how the copyplast is formed. So you saw on the screen a mini star, a biostar, which uses compressed air to push the material around the stone, as opposed to a classic suck down machine, which sucks the material down with a vacuum. When you compress it with compressed air, the detail replication is like superb. That's more important. That's the most important. Like using the compressed air in copyplast is like crucial. So they're sold by Great Lakes. When you raise the VDO in the anterior, do you have to do the posteriors at the same appointment? If you have time, then yes. If you don't have time, it's okay to break it up, right? Because sometimes people go, listen, I don't feel comfortable enough doing the entire arch in one appointment. I have no idea how long it's going to take me. So great. Do your upper anteriors first, and then use the matrix. I would actually use whatever matrix you're using to make them, squirt provisional material in the posterior and seat it over it. And then they basically live and just wear this little matrix. You could do the same thing with biacryl, right? Squirt material in, seat it, and now they have an occlusion that actually works until you get back and you can do the other posteriors, right? So it enables you to not have to leave them with an anterior only contact for however long it is until you can get them back in the practice. So just use a matrix. It's kind of like a night guard, but really quick and easy to make, right? Really quick, low cost and efficient to make. All right. So with that, I want to thank you for spending time after what I'm assuming was a practice day for the most of you. I appreciate you coming on, spending some time with us. Hope to see you maybe live and in person at a workshop at Spear. But until then, everybody be well. And Jerry, thank you for spending some time with us tonight as well.